we had talked about axial musculature, including on the back, there's a deep layer of muscles that are involved in just controlling the posture of the vertebral column and the head. There's a middle layer that's involved in respiration. And then there was a superficial layer that I didn't really talk about. The superficial layer of back muscles controls the upper limb. Then on the front side of the trunk, there's a pectoral region with muscles that also control the upper limb. Down low on the back side of the pelvis, there's a gluteal region that controls the lower limb. And then after these regions, so superficial back, pectoral region, gluteal region, beyond those regions, most of the rest of the limb muscles are organized into compartments. Okay, and the concept of a compartment is really important clinically, as we'll discuss later. Here's how a muscle compartment works. Number one, it has a wrapping of what we call fascia, basically a sturdy wrapping of connective tissue that envelops the group of muscles that are in that compartment. The muscles in a compartment, in a limb compartment, tend to have common attachments. So for example, we just saw for the forearm, the anterior arm flexors tend to come from the medial elbow. The posterior forearm extensors tend to come from the lateral aspect of the elbow. So they tend to have similar attachments. They tend to have similar functions, like their anatomic actions. They tend to have a common innervation and a common arterial supply. So studying muscles, it's very useful to think of the muscles in groups, in functional groups that are anatomic compartments. So for one killer example to use here, the posterior compartment of the forearm, those forearm extensors that we were just talking about, that you can aggravate with a tennis elbow. Their common attachments, they tend to originate from the lateral elbow and they go across the wrist into the hand. What do? Their anatomic actions include extension at the wrist and extension of the fingers, like that. Okay, posterior forearm muscles. They're all innervated by one nerve, the radial nerve. And then there are branches of arteries, the radial and the ulnar arteries. Those are the arteries of the forearm and hand, basically. And those arteries tend to supply all of these posterior forearm muscles. So that's one example of a compartment of muscles that share attachments, bony attachments, actions, innervation, and arterial supply. And that same theme basically is true for one muscle compartment after another. And what we're going to do for this course is we're going to take, for each muscle compartment, we're going to take basically one muscle as an example, occasionally two, as a representative of that group. Okay? So starting with the pectoral region, and again, the pectoral muscles control the upper limb, even though they go from the axial skeleton, they're going out to the humerus. And our example here is the famous pectoralis major, this big muscle up front on the chest. It is responsible for adduction. So I'm going to get a little view here. So from anatomic position, if I start with my upper limb abducted, I can adduct it forcefully, and pectoralis major contracts to perform that adduction. Okay. It's also an internal rotator. So if I want to take my right hand and place it over my heart, for example, that involves internal rotation at my right shoulder, my right humerus is spinning medially, right? So pectoralis major contracts to perform that internal rotation at the shoulder. And in fact, you can demonstrate this. Pectoralis major, as you can see on the screen here, forms a fold at the anterior part of your armpit, which we call the axilla. So if you just grab this fold up front in your armpit, that forms the front of the armpit, and then you contract pectoralis major to internally rotate forcefully, you'll feel pectoralis major contract when you do that. Okay? So that's our representative muscle for the pectoral region. The superficial back muscles, okay, these outermost back muscles, there's a whole bunch of them, many of them, and they're indicated here in orange and yellow. Most superficial of all of them is trapezius. It's a very large muscle here. It's a muscle that controls the scapula. It's attached to the scapula and the clavicle. And that's the girdle of the upper limb. And then if we take trapezius away on the left side of the back here, you can see there are other muscles indicated here as well, and also a large muscle down here. So these muscles control the upper limb, and trapezius is our representative muscle. It moves the scapula. And you can see how trapezius has fibers that kind of from the scapula, they ascend up toward the head and neck. There are some fibers in the middle that just come horizontally straight across toward the spine, and there's some fibers of trapezius that drop down low toward the lumbar spine. So depending on which part of trapezius you activate, you can activate different levels, different parts of it independently. You can lift the scapula up this way. You can depress the scapula down this way. Or if you contract just the middle portion of trapezius, or if you contract all three parts simultaneously, you pull the scapula in toward the vertebral column. We call that motion retraction. You're pulling the scapula medially. And you would do that, for example, if you reach out and grab a drawer handle and then pull your arm back. When you're doing that, the scapula is retracting on the back, on your back. And so trapezius would be active in that. The clinical test for trapezius, if you have a problem with the innervation of trapezius, or if trapezius itself, the muscle, is weakened for some reason, the clinical test is a neurologist will put their hands on the patient's shoulders and ask them to shrug. So you're basically lifting the scapula when you do that. And so you're testing the upper part of trapezius, and if they're weak or paralyzed and they can't lift their shoulder on one side, you know there's something wrong with trapezius or the nerve that innervates it.
Paul, we have a question.
Go ahead.
Do we have to know the origin and insertion of the muscles at all?
Heck no. So I absolutely don't want you memorizing origins and insertions. I may occasionally mention an origin or insertion. And if I do make a big deal, if it shows up on the slide, so for example, this idea that the posterior forearm extensors originate from the lateral elbow, and conversely, the anterior forearm flexors originate from the medial side of the elbow. Obviously, that I want you to know about so that we can talk intelligently about golfer's elbow and tennis elbow. But I don't want you. I mean, you could write a short thesis on all of the bony attachments of trapezius. There's a lot of detail to this, and I don't want you worried about that detail. What I want you to know is basically just that what you see in the picture, because that trapezius has a bunch of axial attachments. We would call that the origin. And it reaches out and grabs the scapula and also up front the clavicle. But importantly here, it reaches out and grabs the scapula. And you can see the spine of the scapula. There's the acromion sticking out there. So when trapezius contracts, it's moving the scapula. Okay, that's sufficient. You don't need to worry about attachments beyond that level of detail. Okay?
Okay.
I'm going to move on to deltoid. So we're looking kind of obliquely down from above on our model's shoulder. And the deltoid is this really massive muscle that forms the roundness of the shoulder, and it's a really powerful abductor or abductor of the upper limb. So it can also, however, flex. Okay, so if I bring my upper limb forward, flexion, deltoid helps with that. It can also extend. So deltoid will draw the humerus backward in extension. And the way that happens is, again, deltoid has multiple heads or bellies. There's an anterior part, a middle part, and a posterior part, and you can activate them independently of one another. So if you activate just the front of deltoid, you get flexion. If you activate just the back part, you get extension. If you activate the middle part, or if you activate all three simultaneously, whoop, you get abduction of the upper limb. Okay, so that's deltoid, and it's a powerful limb abductor. If you reach up and paint your ceiling like that, that's deltoid, and it's deltoid that gets sore after like a minute doing that. Okay, now we're going to move from the shoulder region down into the anterior arm. So this is now technically a muscle compartment that is bound by fascia. The anterior arm, there's actually three muscles there, but we're only going to have one as our representative, and it's biceps brachii, right up front on the arm. Now, biceps brachii is pretty famous as a flexor of the elbow. This is the one that all the weightlifters, and you can see I spend a lot of time lifting weights in the gym, right? The weightlifters will do a lot of curls and develop their biceps brachii, and the underlying muscle also, an underlying muscle is also flexes the elbow. It looks impressive and all. Biceps brachii is actually really important clinically for supination. So again, if I reach out with my hand and do this, I turn my palm toward the ceiling, that's supination. And that is biceps brachii is actually a really powerful supinator. And if you have a problem with biceps brachii, if it's weakened or paralyzed, the patient's probably going to notice that they're weakened supination more than they're going to notice that they're weakened flexion of the elbow, because you have other muscles assisting with that. So supination, again, if you just palpate your biceps brachii and then supinate forcefully, you'll feel it contract. So biceps brachii is a supinator of the forearm. It also flexes at the elbow. On the back side of the arm, we have the slightly less famous, but actually much more powerful triceps brachii. So triceps is a three-headed muscle, brachii for the arm. It's on the back side of the arm, and it is a powerful elbow extensor. So on the quiz, we had that example of striking a nail with a hammer. So we start flexed, biceps brachii might assist with the flexion. And then when we strike the nail, we extend forcefully at the elbow. That's triceps brachii, doing that extension at the elbow. Okay. Now, to the anterior forearm, we discussed the concept of these muscles briefly. They originate from the medial, many of them originate from the medial aspect of the elbow. They curl across the front of the forearm, and they tend to be flexor muscles. Our one killer representative from the anterior forearm is this muscle that's abbreviated FDS. The full name is flexor digitorum superficialis. That name comes from its function, obviously, and also the fact that it's flexing the digits, the four fingers, and the fact that it's toward the surface. It's superficial compared to another muscle that's deeper. So flexor digitorum superficialis is a bit of a mouthful. Orthopedists say FDS, and you're welcome to do that. Anytime you see a bold term like this with a long name, and then there's an acronym that's also bold, that acronym is totally legit. If an acronym is legitimate for clinical purposes, we'll list it in bold. Yeah, that's the anterior forearm muscle that serves as our representative there. And now we've turned around, we're looking at the back side, and you can tell we're looking at the back here because instead of pectoral muscles, we're looking at trapezius. And instead of rectus abdominis and abdominal muscles, we're looking at this big swath of fascia here, and here are the gluteal muscles, right? So we're looking from a posterior view. This is the posterior forearm, and our representative muscle from the posterior forearm. Notice that it originates laterally from the elbow, comes across the back of the forearm. It's called extensor digitorum, and extensor digitorum is the muscle you would use to this, right? So you're going to extend your fingers. The perfect example of this is if somebody asks you, how old is your son, your little son? He's 4 years old, right? So you're using extensor digitorum to extend the four fingers when you do that. Since it crosses the wrist, it also extends at the wrist at the same time. And then finally, I think this is our last compartment that we're concerned with for the upper limb. So if you inspect your hand, you'll notice a large mass of soft muscle tissue here at the base of the thumb. It's called this feature is called the thenar eminence, and the muscles therein are called thenar muscles. I'm not concerned about the individual names of the several muscles that are part of this group. I just want you to know them collectively as the thenar muscles. And they are the muscles that, with other muscles, they control movements of the thumb. And these muscles in particular are innervated by that median nerve. And so these muscles can be weakened or paralyzed if you have problems with the median nerve, say, due to carpal tunnel syndrome. And again, these muscles are clinically very important. If a patient loses the function of these muscles, it's very debilitating. You can't do practically anything you would normally do with your hand if you can't control your thumb.